We heard that 800,000 boosters were administered so far, and the ambition, according to Paul Reid, is that you'll be ramping up to 270,000 boosters a week by mid-December. Now, you had achieved 400,000 a week in the summer. And, there's a lot of impatience, people saying, just get it done, even if it means postponing more electives and so on. Just get it done, because the booster for the HSE is the best way to be able to cope with any surges of other diseases in January, February and winter.
Yes, and it's always that feeling that it's a race against time, but we're building on a much more substantial platform than we did when we set out the primary dosing schedules of the booster campaign. At that time, we were dealing with an unvaccinated, completely unprotected population. And we saw, for example, back there in January, when we saw 5-day moving averages, not much higher than what we're seeing now, but the link between that and the harm that was caused in terms of hospitalisations and admissions to ICU considerably higher. And that conversion rate at that time between the numbers of cases and those who were hospitalised was much, much higher than it is now. 55 perhaps per 1,000 cases hospitalised. Now we're seeing that fall, obviously particularly for vaccinated people, to as low as 15. So that we're building on a much more higher protection platform. We are directing the booster campaign, as is only correct, at those who are most vulnerable, immunocompromised. Now 84,000 have received that extra dose, that third dose that they needed for their primary dosing schedule. We've as good as completed the residential care settings, and we know from the first surge, the second surge, that's the most vulnerable setting. Over 80s substantially complete. Those over 70s we expect to have completed in the next 7 to 10 days. Healthcare workers, 60% of the 300,000 done. So as is the case, we need to prioritise this booster campaign on those most vulnerable individuals, groups that we know carry the greatest risk.
Yeah, and one of the talking points is that the HSE people who weren't frontline staff, who jumped the queue the last time because there was a facility for them to do it, it appears they're going to be offered their boosters even though they would not be the most vulnerable, the most deserving in the pecking order.
Some people look at this as the most deserving. I tend to look at it as many people do, at the greatest risk. And I know, for example, when we looked at our hospitals in January, there were 3 of them perhaps came to within a whisker of closing completely because of the number of outbreaks and the way that the amount of staff that had to leave because of COVID illness or COVID-related illness. There was no point in discriminating in the eye of the storm between those who were absolute frontline staff and those who might have worked in the canteen or records department. What matters is that the virus had multiple portals of entry into healthcare facilities, and our instructions at that time, and I have no regrets about this, was to vaccinate as many healthcare workers as they could in each facility to ensure that we were protecting not just them in terms of whether or not they deserved the vaccine, but to protect the services and the patients they served.
Even people who were working from home.
Well, more people working from home now, certainly, but the priority for us is looking at those healthcare facilities, hospitals, primary care centres, nurses and public health nurses, all those settings. That's where we're focusing. It's those settings that we focused the first time around. Yes, there were some people there who could not be labelled, strictly speaking, as frontline healthcare workers, but the risk they brought into those settings when they had no choice but to attend at work, and not all healthcare workers can work from home. Obviously, a substantial proportion of them have to attend their site. To me, it's not just about protecting the individual, it's about protecting patients and the services in which these people work.
A number of other booster-related issues have come up. For instance, people attending 5 months after their last Pfizer and then being told, sorry, it's 5 calendar months, not 20 weeks. Whereas before, for example, with AstraZeneca, it was always 12 weeks or 16 weeks initially, then 12 weeks, not calendar months. So people being turned away a few days shy of a calendar month, but more than 20 weeks. Why does that happen? Because you should be glad to get jabs in anybody's arm.
I agree. I haven't heard of such reports of people being turned
According
away
to one pharmacy, they had a letter from the HSE instructing them that it should be calendar month, not 20 weeks.
Well, clearly there has to be precision in terms of we give instructions. My own feeling is if people come in a few days short, get them vaccinated. Our aim here is to see the benefits of the booster campaign, and if people are good enough to embrace the booster and turn up and want to get vaccinated, absolutely we should be vaccinating them. But clearly letters do go out to try and give some kind of order or standardisation to the way booster campaigns are run and the timing, and people who are administering the vaccines like to see those. But that said, as I said, our aim is not to turn away but to embrace those,
to get as many
done.
Because there may not be another opportunity for some people.
No.
This is the moment. and it's there. If they got the vaccine, they would feel reassured. Now, the question of people getting two invitations, one because of their age from their local GP, they get vaccinated, then they get an HSE invitation, and I've had anecdotally a number of cases where they've said they haven't been able to reject it appropriately. You know, the system that you've put in place hasn't worked for them, and they feel quite guilty that they'll be listed as no-shows.
We have seen this, and we've seen this the first time around too, and that people that fall into, we have healthcare workers, for example, in their 60s, or sometimes a small number in their 70s, and they fall into two different groups as such, and we've seen duplication of invitations. I would just urge anybody for whom this happens, embrace the first opportunity, let people know. We're seeing, in addition to scheduled appointments, we have walk-ins, as people saw last weekend. We have walk-ins as well, so we have more than enough people at this point in time to fulfil the work of our vaccine centres throughout the country. So take the first opportunity you have, and then let people know. But I'm fairly confident, based on the demand at the moment, that based on walk-in, people turning up without appointment, that there will be no opportunity wasted.
Okay. We get mixed messages, of course, because we're told that, the go-ahead has been given for anyone over 18, but it'll be done sequentially in time. When you have a walk-in centre, if someone walks in who, has got the go-ahead to get a vaccine but isn't in the appropriate age cohort, what'll happen? No,
what we do, and the order there, the hierarchy of risk is there for a reason, Pat, and I'm sure, we've gone through this before, and people know this, and people have a good understanding of this now. And as we've described many times here on your show and elsewhere, we know the risk between being infected with the virus and the risk of harm is very much age-related, and also related to underlying conditions. And it's for this reason that NIAC and other regulatory agencies and other advisory agencies throughout the world have advised this hierarchical approach going down with age. Yeah. So that's the approach we have.